4, 3, 2, 1. We are live.
Respected faculty and dear audience, on behalf of Uttaranchal Orthopaedic Association and on my own, I welcome you this evening in the 4th Symposium of Uttaranchal Orthopaedic Association this summer. That is the Foot and Ankle Symposium. It is my proud privilege to welcome and introduce our learned faculty to all of you. First of all, I would like to introduce Dr. Naresh Agarwal from Ludhiana. He is a renowned figure who has been professor of orthopedics in CMC and DMC Ludhiana both. He is pioneer in many things including the interlock nailing in India. He is founder and organizer of many subspecialty conferences at Ludhiana. Welcome you, sir. I would like to welcome Dr. Jayant Sen from Jaipur. He is known for his love for IOA and ROSA. He has been secretary and at many posts in ROSA and has been very active in organizing seminars and conferences in the various parts of Rajasthan. Welcome, Dr. Jayant.
Thank you.
I would welcome
Your kind words.
Dr. Kamal Dureja. He is Director, Foot and Ankle at Max Super Specialty Hospital, Delhi. He has been a pioneer in foot and ankle, and I have attended many of his programs, and I am definite that he will be very beneficial to the audience. Welcome, Dr. Kamal.
Thank you.
I would like to welcome King Shantanu. He is a pioneer from not only from Bihar, but he is very well known for his zeal for the Foot and Ankle Society. He has been secretary and he is a very key figure in Foot and Ankle Society. And I am proud to say that I was also made member during his secretaryship. Welcome, Dr. Shantanu. And we will be welcoming our new faculty, Dr. Pradeep Meena. He is from our own state, Uttaranchal. He is assistant professor, additional professor in AIMS Rishikesh. Welcome, Dr. Pradeep.
Thank you, sir.
And not the least, I would welcome our dynamic secretary, Dr. Puneet Agarwal, who is behind all these symposiums, working hard and taking the organization, Uttaranchal organization, to new heights. I welcome
you,
Dr. Puneet.
Thank you.
The topic for today's talk for Dr. Naresh is Haglund's deformity. I would request Dr. Naresh to please share your screen and start your presentation.
Thank you very much, Dr. Siroli. Right. Is my screen visible to everybody? I hope so.
Yes, sir, it is.
So we are going to talk about, just a minute, it is not moving forward now. We just checked it was, yeah, it is moving forward. So we are going to talk about Haglund's deformity. I'm sure everyone knows Haglund deformity. This is what it is. It has got different names and synonyms. It was first described about 100 years back, and the name is after the surgeon Patrick Haglund. Now, when we talk about Haglund's, for the sake of convenience and understanding, I'm going to talk under these headings. Apart from first talking about synonyms and overview, I'll briefly talk about its causes, if there are any, how is the clinical presentation, what is the differential diagnosis, the radiological features, some aspects on prevention, and then treatment, conservative and surgical both. Finally, the complications. And I hope at the end of these 10 to 12 minutes, I'll be able to leave a small take-home message, simple enough to be remembered by all the delegates. You know, if you look at the anatomy of the heel is found by the calcaneum, we all know it. Now, and then at the back of the calcaneum, the tendoachilles is inserted. Just between the tendoachilles and the upper part of the calcaneum, there is a bursa, which is called retrocalcaneal bursa. And just by the anterior to it, the calcaneal bone projection is called the bursal projection. And this is where the Haglund deformity starts. There can be extra calcification here or exostosis here, or it becomes more prominent. And that is what is called Haglund's deformity. It may or may not be associated with bursitis of this bursa and tendinitis of this tendon. Tendoachilles, the strongest tendon of the body. There can be insertional tendinitis or tendinopathy. There can be avulsion. There can be rupture. There can be just tendinitis. So different levels of tendon involvement can be there with Haglund's deformity, or there may not be a tendon involvement. So the tendon involvement actually decides the prognosis of treatment in Haglund's deformity. Now, what are the synonyms? It has been called by different names, and most commonly, I always call it a heel bump. It can be pump bump, heel bump, knobby heel, cucumber heel, winter heel, skater's heel, highbrow heel, calcaneal altus, or Mulholland deformity. Now, Haglund syndrome is slightly different from Haglund's deformity. Haglund syndrome is when everything is there. There is a Haglund deformity, there is bursitis behind the calcaneum, and there is tendinitis. The involvement of tendon can be variable, as I said. And when all these three are there, we normally call it Haglund syndrome. Now, this is Haglund syndrome. You can see some extra bone prominent of the calcaneal bursal tuberosity. And then there is bursitis and tendinitis with the posterior, bump, formation of a bump there, convexity along the heel. So this is Haglund syndrome. What causes have been attributed for this may or may not contribute, but by different authors, these are the causes which have been considered towards leading to Haglund's deformity. High heel with hard back shoes, high arc or cavus foot, that causes the calcaneus to be vertical, and then that it hurts the tendon and it causes some deformity at the posterior part of the calcaneum. So cavus foot or tight TA, it can be hereditary. And if there is a tendency to walk on inverted heel, that can also cause irritation of tendon and calcification at the bursal tuberosity of the calcaneum. Clinical presentation, as we have already seen, most common is pain just anterior to the insertion of tendon and superior, which is worse in the morning, and it increases on dorsiflexion as it rubs against the tendoachilles. There is swelling, there can be redness, there can be hardening of skin, sometimes the skin can ulcerate, and in later stages, as I said, there can be different grades of involvement of tendoachilles, including avulsion or rupture. It is usually seen in middle-aged females, and quite often it is bilateral. What can be the differential diagnosis? Well, at that place, apart from the bone, there is bursa and there is tendon. So there can be bursitis or tendinitis. That is the differential diagnosis. Now, this is actually the Haglund's deformity. You can see a very clear, prominent bursal tuberosity or exostosis at the posterior part of the calcaneum. And if you look at the other slide, this is not the Haglund's deformity. This is the calcaneal spur, insertional tendinopathy. There can be calcific tendinopathy or there can be bursitis. So this is not exactly the Haglund's deformity, but sometimes this is associated with Haglund's deformity, and then we call it Haglund syndrome. Radiological features, the diagnosis is mostly clinical, which is confirmed by radiology. If you see this extra bone just anterior to the tendon, this is diagnostic, and this is the clinical, this is diagnostic of heel bump. It may be, in this case, there is slight insertional tendinopathy of the tendoachilles. So there is increased bursal projection, the bursal projection of the calcaneum, that we call it exostosis. There can be calcific tendinitis. There can be posterior calcaneal spur if there is insertional tendinopathy. Obviously, there will be in the X-rays or MRI or even an ultrasound, there will be convexity of posterior soft tissues. There are some radiological lines and angles described, but I doubt if they are of any clinical significance. I have never found them of much help in my diagnosis and treatment, but nevertheless, for the completion of talk, I will talk briefly about these lines and angles which have been described. I only remember them when I have to give a talk on Haglund's. In my clinical practice, I've never measured them. I should be honestly admitting that. So, in lateral views or MRI or ultrasound, you see loss of Traeger's triangle. Traeger's triangle, I will show you what it is. Thickening of tendoachilles more than 9 millimeter above the bursa is usually diagnostic of tendinitis. There can be prominent bursae. And in MRI, you can see marrow edema of the calcaneal tuberosity. So now this is a calcaneal spur, as I said earlier, and this is not to be mistaken for Haglund's deformity. It can be associated. Now this is the Traeger's triangle. If you see this slightly radiolucent area in front of the tendoachilles, this is Traeger's triangle. And if there is thickening of tendon, sometimes this is obliterated. Calcaneal pitch angle, it indicates verticalization of the calcaneum. If the calcaneum is verticalized or the cavus is there, then there are more chances of Haglund's deformity. So with this angle, we can measure the verticalization of the calcaneum. Usually it is in females, it is verticalized. These are pitch lines. This just shows some extra bone formation over this line, two parallel lines from here to here. And then there are some other angles which indicate some bone formation above the calcaneal bursal projection. Another angle, I don't know how to measure this, but this is how it is. If I go in detail, I think I'll be wasting time. This is Traeger's triangle. This is quite often visible in the X-rays, and sometimes it is obliterated, means there is thickening of tendon. This is, like a fat pad, but it is not. All of this is not fat pad. People have tried to classify it, Haglund's deformity, with or without involvement of tendon. Stage 0 to stage 4. Stage 0 means there is no tendon involvement. Stage 1 is very minimal tendonitis. There may be some on MRI focal areas of high signal. And in stage 2, there is slightly more involvement. Stage 3 is definite thickening with bursitis and tendinosis with marrow edema. And stage 4 means there is tendon rupture. So this basically, as we go from stage 0 to stage 4, it becomes more severe and more poorer prognosis. Prevention, yes, if we remove the causes, we can prevent it. Appropriate shoe wear, appropriate arch support, stretching exercises, and we can avoid running uphill on hard surfaces, which will, that this particular activity would irritate your tendoachilles and would make it rub against the bursal projection. So these are the things which we can do to prevent formation of this Haglund deformity. Treatment, like in every orthopedic condition, there is conservative treatment and there is surgical treatment. The conservative treatment is standard traditional. You can give some anti-inflammatory if there is inflammation, icing, appropriate shoe wear, heel inserts or heel raise to relax the tendoachilles. Most important is the stretching exercises. Ultrasound and shockwave therapy has also been written about to have to be of some help. And sometimes if there is element of bursitis, you can give ultrasound guided steroid injection into the bursa to cool that inflammation down. Now, what I have seen in my practice, and is also supported by literature, that quite often, as this is seen in middle-aged ladies who are post-menopausal, and they have an element of osteoporosis, and vitamin D is mostly deficient in our population. So if we give supportive treatment, including anti-osteoporotic treatment and vitamin D supplementation, a significant number of these patients improve with other, supportive treatment along with the conservative treatment. I have found more than 50% or about 50% of the patients respond to this. and then they don't no longer complain of the pain or swelling which is there at the back of the heel. So it can work in about 50% of cases in my practice. Now, surgical treatment. What are the indications? Failure of conservative treatment, which should be done at least for 6 months. We should not rush for surgery. At least 6 months and thoroughly investigate the patient. If there is high uric acid level, take care of that. If there is anything else positive in his investigations, bone biochemistry or anything, we must set that right and give the conservative treatment, stretching exercises, at least for 6 months. So that if it's 6 months conservative treatment has failed, then that becomes a definite indication for surgical treatment. Or if the symptoms and the problem has recurred after conservative treatment, then you are justified in doing surgery. What surgery we do? Usually a resection of the bony prominence, because that is what is causing problem. Excision of the bursa if it is fibrosed and inflamed. Debridement of the tendon if there is any degeneration within the tendon. If it is avulsed, we need to reattach. If it is avulsed and retracted and you can't bring it back, or it is the more than 50% of it has to be debrided, then you can consider FHL transfer a lot to the tendoachilles. So this is the surgical component, and this is what we do in surgery. How do we do this surgical thing? There are three options. We can do open surgery, we can do endoscopic surgery. And then there is a calcaneal osteotomy to achieve these objectives, which has been described in literature. I have no personal experience of endoscopic surgery or calcaneal osteotomy. I do open surgery and I'm quite happy with it. I'll show you different grades of cases of open surgery. Now, what do we do? How do we do? Midline posterior. That is what I do. I go straight posterior tendon splitting incision. Some people do lateral, but I prefer midline. Avoid making flaps, avoid use of cautery, split the tendon, go directly to the bone and resect adequate bone. Debride the tendon if there is necrosis and you can see necrotic area. Reattach the tendon if it is avulsed, preferably with bone anchors. And if more than 50% of the tendon had to be debrided, then it is better to supplement this with FHL transfer, flexor hallucis longus transfer. Postoperative, about 10 to 12 weeks in cast. The first cast is for 3 weeks in plantigrade position, and then I bring it to the neutral position. And after that, you can carry that on. And I usually do a Bijlani cast in these patients. Now, I will show you 2 or 3 cases, one without tendon involvement, one with tendon avulsion, and one with tendon rupture, old cases. Now, the first case, this was otherwise simple, but patient was diabetic and she had problem for 2 years, and there was some tendonitis, but the tendon, it was not avulsed, there was not much degeneration of the tendon. So this was the X-ray. There was some calcific tendonitis, but otherwise it was all right. You can see the exostosis. So we went through the midline approach, excised the bone and reattached the tendon with the bone anchors. And this is the midline incision that I was talking about, split tendon incision. And in this case, after 6 months, this is, I think, after 3 months after removal of plaster. Good healing, no complications, despite her being a diabetic, and there was good function. And this is, we are quite happy with this approach. Second patient where the tendon was avulsed for more than 7 months, and there was a very big gap. We were not able to bring back the tendon to bone despite doing VY-plasty, and we therefore did the FHL transfer along with that, which we sutured to the tendoachilles and passed the FHL through the calcaneum. This was the case. Tendoachilles was avulsed from here. There was a big gap, and this is the postoperative X-ray. And this is after about a year. This hole has healed. This is the hole through which the FHL was passed. And this is the anchor suture used for suturing the tendoachilles back to the calcaneum. Third case, now in this case, there was a tendon rupture with a very big gap, about 8 centimeter gap. And it was the most difficult case. Here we did almost the same thing. There was a small stump, but that could not be used. And she had a bilateral problem, but the rupture was only on the left side. This was the side which was ruptured. And there is some, calcaneal spur calcific tendinitis you can see. You can see the MRI tendon is detected quite up. There is a big gap here. And again, the same approach. We had to extend the midline incision proximally to get the, as much as lengthening possible to close the gap. Still, we were not able to close the full gap. Then we gave this medial incision on the foot to get the flexor hallucis longus tendon from there, cut it from there and retract it into the incision. And then again, go through the, hole and anchor this tendoachilles back with the bone anchor. This is after 6 months, very nicely healed scars, good range of motion and good power in tendoachilles. So normally 2 approaches as described. This is the midline split tendon approach, which I prefer and I do. Then there's some people do the lateral approach. But there has been a study comparing lateral approach to the midline approach, and the conclusion was that through lateral approach, it is difficult to reach medial side of the bone and also to visualize the interior aspect of the tendon. And there are slightly more wound problems in the lateral approach. And that is of the comparative study, which has been published about 15 years back. Endoscopic surgery, as I said, I have no personal experience, but it is indicated only when there is no significant tendinopathy. So we can do with endoscope. It is a very minimally invasive approach done under local anesthesia. There is very little postoperative pain. One of our colleagues, Dr. Raja from Chennai, he does this routinely and he has excellent results. He has shown there is hardly any damage to tendoachilles. He just runs his burr and brings out the bone mud, I would say, through a small incision. And it is the outpatient procedure. There are hardly any wound problems and you can start early weight bearing, leading to quick recovery. These are some of the photographs you can see. The endoscopic approach picked up from the literature, not my own, but fairly good procedure when there is no tendon involvement and quick recovery outpatient procedure. Now, there has been a meta-analysis and review of open and endoscopic surgery. And obviously, as we could expect, the complication rate favors endoscopic surgery over open surgery. But then again, the indication of the 2 are different. It is more simpler cases for endoscopic surgery. But whatever technique we use, whether it is endoscopic or open technique, we must do sufficient bone resection. That is the primary thing required for a good result and good wound healing. Now, I also spoke, the other option was calcaneal osteotomy. This has been described a few years back. It's a dorsal wedge-based osteotomy, just in front of tendoachilles, and you remove that extra bone through that wedge. And this is how this wedge is taken out, and then you screw this part of the calcaneum back into the main fragment, and you take the extra bone out and relieve the pressure on tendoachilles. This also is indicated when there is no tendinopathy, no significant tendinopathy. What can be the complications? Well, all complications, common complications in any orthopedic surgery: delayed wound healing, infection, persistent pain, stiffness, neuroma, painful scar, weakness of tendoachilles, and recurrence. All these complications can be there, but if done properly, it's a fairly satisfying and rewarding procedure, and the results are very, very good in our hands. Poor prognostic factor, like any comorbidity and overweight, that is for the general, but in this case, tendon rupture and extent of involvement of tendon increases is a poor prognostic sign. The higher the extent, poorer the prognosis. However, we can still get very good results in these patients, as I have shown you in the couple of examples that I showed. Now, to conclude, the take-home message for an average surgeon practicing foot and ankle surgery would be that surgery should be considered only after failure of conservative trial for at least 6 months, or if it has recurred after conservative treatment. Midline posterior tendon splitting approach is safe. Do not hesitate. For a long time, I was reluctant to do this approach. I used to do a lazy S incision or a lateral or a medial approach. But last few years, I have used this approach and I'm extremely, extremely happy with this approach. We should avoid, of course, use of cautery and raising flaps. Adequate bone excision is the key to good result. Consider FHL transfer if more than 50% of tendon had to be debrided, or if there is very significant retraction, you cannot bring it down, bring the fracture hallucis around, and endoscopic surgery in selected cases, and so is the calcaneal osteotomy. Thank you very much, and that is it from me.
Thank you, Dr. Naresh, for the elaborative talk on the subject, which has been not sometimes known to average people. So thank you very much, and we would have at least about 5 minutes for the discussion part. So anything from the panelists, please
Yeah.
go ahead.
So as Dr. Agarwal said, endoscopic calcaneoplasty. I do this endoscopic calcaneoplasty, and basically I just want to tell you how to select which are the cases which are restricted for endoscopic calcaneoplasty. I do an MRI, and if I find marrow edema in the fat suppressed images in the Haglund tubercle, they are the best cases who would respond to an endoscopic calcaneoplasty. And if I find in the presence of marrow edema, there is a minimal tendinosis or calcification of the tendon, they are going to respond very well. However, patients who have lot of calcification in the tendon, you can see them in the axial view. If there are signal changes in the axial view of the calcaneals, which are more than 30%, always be ready to do a debridement by open method. And if there is a significant heterogeneity in the Achilles tendon in the axial views of the MRI, then the best is to do a good debridement and plan an FHL transfer. So these decisions about which patient to do which particular procedures are very well based on the MRI pictures of the Achilles region.
Got the point, sir. Yes, Dr. Shantanu.
Nicely explained, sir. Yeah, so that was very nicely explained. First of all, it was a wonderful talk by Dr. Agarwal, sir, as always. And the explanation further given by Dr. was also excellent. But from the perspective of a general orthopedic surgeon, I would like to stress here that during my early days, during my MS days or my SRship days, I was very much inclined to call any posterior heel pain as retrocalcaneal bursitis. And even today, it is not very uncommon that as soon as the patient comes to the OPD, to the office orthopedics, many of our colleagues call it retrocalcaneal bursitis. So that is not the case. My message is that a good clinical examination is very important. Coupled with a good quality X-ray, the diagnosis can be placed and then managed accordingly. Most of the patients, as pointed out by Dr. Agarwal, sir, they respond to conservative treatment. Those patients who do not, for a reasonable period of time, which as long as 6 months, then we must not hesitate to surgery. But surgery should be done with good technique so that there are no wound complications. Certain very important point pointed out by Agarwal sir was that as the cautery is not to be used. The incision is to be direct and adequate bone is to be resected. So that is what I'll stress as a panelist.
Thank you, sir. One thing came during the retrocalcaneal differential diagnosis, and that's very important also about the about the steroid injection. It has been seen that the ruptured tendon has been reported after the steroid injection. So, what do you recommend about this? Should it be promoted? Should it not? Or
No,
what?
Dr. Sirohi, first of all, I personally rarely, I would never inject a steroid in the heel, but still, it is written and it is well known accepted treatment. Now, how to avoid complication with steroid injection? First of all, it should be ultrasound guided. Yes. So that you are very sure where you are. You should not be into the tendon. If you are into the tendon, it will rupture. You have to be in front of the tendon into the bursa. That is the only place to give steroid injection for this particular diagnosis. I have myself had my long head of biceps ruptured 4 months back by an injection given into the tendon. So I think we have to be very careful.
I have one
few tips.
Yes, sir.
Sorry. I think with me observing a lot of cases coming to me with Achilles rupture after steroid injections, I think it better be avoided because the bursal injection will also have an absorption of steroid by the peritendinous layer. So it will affect, even if you just give it in the bursa, it will affect the tendon. So it should be avoided.
Yes,
So
I would
can
agree.
the Canacort be given?
Whether you give Canacort or you give
Medron, it is the same thing.
Both are same.
Okay.
Canacort is slightly less granular. So, but as Dr. Dureja has said, that it is better avoided.
Yes, sir.
And
They're actually more harmful than beneficial.
I never use this in my practice, but since it is mentioned in books and it is accepted and many clinicians use it, for the sake of completion, I did include it in my talk.
Yeah.
Sir, I have stopped it for the last 20 years.
You see, as the super specialties are developing, the books on super specialties, they write clearly, don't give it. But the books which are written for general orthopedicians and which have been written 20 years ago, they just carry this thing that can be given, can be given. But I
Dr.
feel
Puneet, any question about it?
I see,
No, sir, there is no question,
more
but
tendon
what
ruptures
I am
because of steroid injections than because of trauma. And there is a village near the city of Bharatpur where there is one quack who is famous for giving heel injections. So every month, I think I get 2-3 patients from that village. So he's doing good work for my practice.
I think there are many people who are very fond of these injections, including our colleagues.
In fact, I've had a situation where I've had Devrani Jethani come together with bilateral rupture into Achilles. So it was a family issue.
Agarwal sir, there is one question.
Yes.
Sir, in case of Haglund syndrome, sir, where the distal Achilles tendon is calcified, what extra treatment will you recommend?
We remove all the calcified part of the tendon. Calcification in the tendon has to be excised. And then the tendon has to be reattached.
Okay, then we have to supplement with FHL.
Not necessary. If there is not much damage to the tendon itself, it is just tendinitis, calcification at the insertion. You remove the calcified mass, all calcified tissue has to be removed, and then assess. Have you debrided, taken out more than 50% of the tendon? Can you reattach the tendon to the bone adequately. If you can reattach the tendon adequately and not much of the tendon mass has been removed, more than 50% is still there, you might get away without the FHL transfer. It is assessment on the table.
So you showed one X-ray where you put one 5 mm anchor, I think. So, sir, is one anchor is 5 mm anchor to hold the tendon?
Actually, you know, as Dr. Dureja said, the specialist literature and the super specialist books, they say use at least 2 anchors. But our patients are poor. First, I used two. In one case, I used 2 anchors because that patient could afford, and then I tried to use 1 anchor only. And whatever is available and convenient, 5 mm can also be put. There is no harm as long as you put it deep inside the bone. It is not projecting out. It should be all right.
Is there any literature suggests that can we put IFS interference screw which we are using in tibial tunnel in ACL?
Yeah, I think there are 1 or 2 reports which says you can put the screws also. What do you think, Dr. Dureja?
So I fix all my FHL with interference screws, because then you don't have to dissect, make another wound in the foot to take out the long FHL.
The short FHL will do.
I divide the FHL which is visible going under the talus. I just divide it there, and this length is sufficient to go into a hole made into the calcaneum, and it is fixed with an interference screw. I hope someday I will be able to show you the full surgery where I do the FHL transfer, fix it with an interference screw. And then the tendoachilles, I fix with 4 anchors. This is called a speed bridge. This is called a speed bridge technique.
Yeah.
And when I do this speed bridge technique fixation of the Achilles, I make the patient walk on 3rd day without a cast. No cast, and patient walks full weight bearing on 3rd or 4th day. So that's the beauty of doing a double row tendoachilles repair combined with FHL fixed with an interference screw. So that's the global standard now.
Yeah, I think what Dr. Dureja is saying is absolutely correct. You know, the modern, they add 2 rows attachment of tendoachilles and interference screw. But, as I showed what I used, that is, it adds to the cost. Every screw, every anchor adds to
very
the
much.
cost.
These are all these
enhances the cost very much.
Yeah,
and even if I put a plaster, patient is fully weight bearing. There is absolutely no non-weight bearing, never non-weight bearing. Cast is just to protect. The only thing patient has to do is they take care of the cast.
Yeah.
And against, you increase the cost by 40, 50, 60, 70,000, making 5 implants.
Very right.
And that I think, and we have to, modify and adapt to the patient's socioeconomic status without compromising the results.
Very right.
It does not compromise the result. And,
a few tips I would like to share, sir.
Okay.
In my cases, after cutting with the saw, the edges remain sharp. So what I do is smoothen the edges, and other than this, at the most lateral and middle aspect, there are after cutting with the saw, the most over the middle and lateral aspect, there are some prominences left. So I try to digitally palpate those and try to dissect them individually.
Yeah, that's very important. Yeah.
Dr. Dureja, I would request you to please share your screen.
Sure, sir. Thank you.
Friends, our next speaker is Dr. Kamal Dureja, and he will be talking on the tips of open reduction and internal fixation of calcaneus.
So just few technical tips which I feel are not bookish, but I have learned over the years. I am sharing with you, and I'll be open to still, if there is any understanding left, I would be most glad to answer them. So all calcaneal fractures, remember this, they are to be treated after evaluation by a CT scan. Now, when we don't do a CT scan, there is a very clear indication. If you find that after the fracture calcaneus, the angle of Gissan and Bowler angle have not changed, they are within normal range, no need to do a CT scan because these are Sanders type 1. So you don't do CT scan, just manage them conservatively. But if you find your Bowler angle and Gissan angle, which are seen on the lateral view of the X-ray, they have changed, means you have deformities, you have issues which will be seen only by a CT scan. So the axial CT scan, what do we look in the axial CT scan? We look at this primary fracture line. We look that mainly the primary fracture line produces two big fragments, the tuberosity fragment and medial sustentaculum or constant fragment. So always look for these two fragments. Look how they are oriented to each other. Are they oriented normally? Is there a displacement or not? If there is a displacement more than 2 millimeter, if there is an angular deformity, then that means these are the cases which require open reduction. So here you see the different cuts of the axial section. So you find pretty big displacement. You find there is a lateral wall fragment. This is the lateral wall fragment, basically the exostosis or the lateral widening which takes place is because of this split fragment bulging out. And this is the fragment which would impinge the peroneal tendons. And then you see this tuberosity orientation, it has changed. It has gone into varus. Thus, varus is seen in comparison to the medial sustentaculum fragment. And then this is the fragment which you see impacted. This is basically the lateral joint fragment. So you must be able to distinguish these four fragments, because these four fragments, if you have learned the orientation of these four fragments, you have to reduce basically these four fragments to get your calcaneum done well. So these are the axial views. Now you will see the coronal views. Coronal views help us to distinguish our fractures into type of Sanders fracture. So we look at the widest part of the talus, where the talus is widest, and then we look what kind of fracture line are we seeing. We are seeing a fracture line here, and we are seeing this as a joint fragment. So this is the lateral joint fragment, same fragment which we were seeing in the axial view. This is the one lying here in the coronal view. So that's how you see the lateral wall fragment which is depressed, and this is the one which has made your posterior facet incongruous. And this incongruence, if it is not reduced well, it will always result in subtalar arthritis. So you are making your orientation by seeing this coronal view, and then finally, you know that we are able to know the anatomy of this fracture. In the coronal view, we are seeing this as a lateral joint fragment, lateral wall fragment, sustentaculum fragment, tuberosity fragment. So you see this again. So this is the tuberosity fragment, this is the lateral wall fragment, this is lateral wall fragment, this is the lateral joint fragment. So that's how you are going ahead by understanding the anatomy of this fracture. And this is the sagittal view, more like your lateral X-ray. But here also you see the different tilt, the depression of this lateral joint fragment. So if this is depressed, this is not well congruent to the posterior facet of the talus. That means it is displaced. And if it is displaced, then it will definitely result in arthritis unless reduced. So all this gives you an understanding, I hope, that once you analyze all these things and you leave them alone for conservative treatment, these patients are bound to have subtalar arthritis and pain due to peroneal impingement, etc., etc. But I am going to here tell you how analyzing these fragments will help you in operating these patients and reducing them. So let's start moving towards that. So again, I'm revising it again. We have done the evaluation of the calcaneal fracture. we are trying to understand the lateral view pathoanatomy. So here, this is the tuberosity fragment, this is the lateral wall fragment, this is the lateral joint fragment, and this is your anterior tuberosity fragment. Now, when you are seeing the lateral or sagittal cut, you are not seeing the medial. The medial one you will see probably if you as you go more medial. So this is how a diagrammatic presentation of the CT view which I just showed you. This is the diagrammatic presentation to understand that you see the lateral wall fragment here, you see the lateral joint fragment here, the tuberosity fragment, and the anterior fragment, anterior tuberosity fragment here. Now we should know what is the main basis of reducing the calcaneal fracture intraoperatively. Sustentaculum fragment, or the most medial fragment, is the one which is why it has been termed constant, because it doesn't move much. It stays where it is. It is lying at the most anatomical place because it is attached with very strong ligamentous attachment to the talus. Hence, it doesn't get displaced. So you reduce everything to the sustentaculum. You reduce, first of all, your tuberosity to the sustentaculum, and then you gain what you call the alignment of the calcaneum, and then you reduce the intra-articular fragment, and then probably the anterior tuberosity if it is broken, and that replace the lateral wall, and then you fix. So all you do this is through lateral extensile approach. Though you can do it with sinus tarsi approach also, but I'm not going to discuss that today at all, because that's a step ahead. You know, once you have done a few of them with lateral extensile approach, then only you will understand that how can you manage all these reduction steps in the sinus tarsi approach. So the prerequisites for extensile approach, however, are that there should be wrinkle sign positive. So you may have to wait 3 days, 5 days, 7 days for the swelling to reduce so that the wrinkle sign appears, because your flap is going to necrose if you do it in the acute stage. And you have to prepare your OT, you have to mark your incision, you have to try to understand, are there any neurovascular issues? Is there any neuropathy? Is there any ischemic issues in smokers or in peripheral arterial disease? Because they are the reasons for your flap necrosis, and try avoiding doing this approach in people who have neurovascular issues. So rule out smoking, diabetes, and a soft tissue insult unless and until the wrinkle sign is present. You can even consider Doppler studies if there are any, if you can't feel posterior tibial artery or dorsalis pedis in these patients. So this is the kind of wrinkle sign which is demonstrated by dorsiflexing the foot and everting the foot. So if these wrinkles are appearing, that means you're safe to go. All right, so this movement is showing the wrinkles are appearing. So these kind of patients with fractured calcaneum can be taken up for lateral extensile approach. So before you do this, you have to do a strict elevation, cold compresses, and wait till the wrinkle sign appears. Rule out neuropathy. Positioning. I like to do it in lateral decubitus position, but you can do it in prone also. So whenever I have bilateral calcaneal fracture, I do it in prone position because I don't have to change the position midway. But if it is single side, it's a good idea to do a lateral decubitus position. And you should have the locking set of 3.5 and plate, and though a new plates of 2.7 mm locking with variable angle is also available, but that's your choice. The job done is same. But you must have plenty of 1.5 mm K wires, which will help you in the various steps of the reduction. So whatever reduction you do, the basis is that you have to give an architectural support to your calcium, which is in the form of a triangle. So you must have tuberosity well fixed. You must have the raft well supported. You must have the anterior tuberosity well supported. So this is in the form of triangle. So if you see various different plates, they all aim at giving you this triangular configuration, whether it is a perimeter plate or whether it is a locking plate by Synthes or the copies of any of these two made by others. The purpose is same. Now, before you start your operation, always position your C-arm and position it in such a way that without moving your heel, without moving your foot, you are able to see a lateral view, an axial view, and broaden view to see your facet congruity. So this is the way I put my slightly oblique. You can see the lateral decubitus position, and the C-arm has been placed oblique. So in the same position, in this very position, you are able to see the axial view. And you just rotate and bring your C-arm in the AP configuration, and you are able to see the lateral view of the calcaneal. So always position your C-arm in this position. Tell your, before you start your surgery, tell your technician, you just want these two views mainly all through the surgery. You do the marking. Now the marking is basically two parts. One is the vertical limb and one is the horizontal limb. The horizontal limb has to be at the junction of the plantar skin and the dorsal skin. There is a distinct margin there. So that is the horizontal line of your extensile exposure. And just 5 millimeter lateral to the Achilles tendon. Don't go close to the fibula. Just 5 millimeter lateral to the Achilles tendon is your vertical limb. And wherever the two are meeting, don't let them meet in a sharp way. Make that end corner a rounded corner. Because rounded corners always have less flap necrosis than the sharp corners. And then mark your anterior tuberosity, cuboid, metatarsal, so that you know if you have to extend this particular horizontal limb, you can go towards cuboid if you have to handle tuberosity fragment, which is also broken. So why do I say you have to stay very, very posterior? Because the moment your incision goes little anterior, you can cut off these blood vessels. This is the branch of the peroneal artery, which is working like an end artery. So if you incise your, give your vertical incisions more anteriorly, this part is likely to necrose because it will lack the vascular supply. So stay posterior, like you are seeing here. Stay posterior, you will never have a skin complication. I hope I'm clear here, showing you what prevents the flap necrosis. So this is one of the ways how you raise your flap. So you raise your flap without putting retractors. You're just either holding with thumb or with the back of your forceps. So you raise the flap till you can reach the subtalar joint, feel it, put a K wire there in the neck of the talus, let the wire go into the neck of the talus, and then bend this wire so that this acts as a retractor. Do not use any retractors and destroy the vascularity of this flap. Because the person who is retracting may be overzealous in retracting and may be doing a retraction which will compromise the vascular supply. So once your flap has been raised, now identify your fragments. Identify where is the lateral wall fragment and remove it. Keep it on the back table. Identify where is the tuberosity fragment. Identify where is the sustentacular fragment. Because unless you remove the lateral wall fragment, you will not be able to see the sustentacular fragment and the lateral joint fragment which is compressed. So it is important to remove this fragment from the calcaneum and keep it on the back table. Here is what I'm trying to demonstrate, though not a very good vision, but I'm delineating that lateral wall fragment and removing it. You can see it's being removed and kept on the back table. And underneath this only we are able to see the depressed joint fragment. So as soon as you remove this, now this is right in front of you, remove the lateral wall fragment. Then you are seeing the tuberosity fragment, then you are seeing the joint fragment, then you are seeing the medial sustentaculum fragment. Now you have to pass a Shan screw. This Shan screw helps in reducing the varus, the impaction of the tuberosity fragment, and you do a maneuver whereby you give an axial traction posteriorly, downwards, and you rotate it to correct the varus. And this now you set your Shyam into an axial view. You must be able to see in the axial view that you have restored the medial wall. So that's important. As soon as the medial wall is restored, pass to K wires, which will hold tuberosity and the sustentaculum fragment, but they will spare the lateral joint fragment. These wires should be passed as medial as possible so that your lateral joint fragment is not difficult to be reduced over it. So this is what I'm showing you here. This is the Shan screw which is being passed in the tuberosity fragment, which will be reduced to in relation to the medial sustentacular fragment. And then we see it in the Shyam. We are able to reduce the medial wall and pass a K wire. Once your K wire is passed, you can remove the Shan screw. So one wire is fixed. Another wire you pass, just pass two wires so that it holds well. And whenever you are doing rest of the maneuvers with the calcaneal, so two wires have been passed, they are holding well. Now you can see the medial wall is well restored. So this is the first step. Now this Shan screw can come out. So once this comes out, you reduce your lateral joint wall fragment, restore the posterior facet, and then fix it with a K wire. See this. So this is you're reducing your lateral joint fragment and passing a K wire. And now you can fix this fragment using a lag screw or a simple position screw, 3.5 mm point.
Yes, sir.
Once you have reduced this, your tuberosity and sustentaculum fragments are already being held. Lateral joint fragment is what you need to do is now okay. So now you want to put your lateral wall fragment from the back table back on the calcaneum lateral side, and then position your plate and see it in the Shyam. What is the best position which will give you a triangular configuration? And my tips regarding the plates and the choice of plate, these tabs in the plates can be cut. So these should not be bent, but they should be cut so that the plate is not oversized. You must have about 5 to 10 millimeter boundary left on all sides, especially at the corner. Otherwise, you have a chances of flap necrosis or burden on the flap, and that can lead to, exposure of the plate. So start with one or two cortical screws, one in the posterior tuberosity, one in the anterior tuberosity. And this will make the plate sit very well over the calcaneum, and rest of the screws you can pass locking screws, which will give you a stable configuration. And you don't need to, when you lift your lateral joint fragment, there is a big void left. You don't need to graft it because the locking screws, they act like a raft. They support it. And whatever hematoma forms in the central part ossifies in a period of 2.5 to 3 months. So that's how you're passing the locking screws in the raft part. You have fixed this plate by the anterior and posterior screws, and now you are just completing rest of the screws. And finally, you do check the length of each and every screw. You do check the reduction of facet, and then you pass a drain, just a very small drain here. Do not create vacuum, just let it have a dependent drainage. Otherwise, you will have 500 ml blood collected in it if you create a vacuum in your drain. This evacuation or this removal of post-operative hematoma is also helpful in survival of your extensile flap. And just simply do a soft dressing with ortho. No plaster is required, no slab is required. Just do a limb elevation, do a drain removal after about 36 to 48 hours. Start early ankle and toe exercises, but keep the patient non-weight bearing for 8 to 10 weeks, depending upon the comminution and the bone quality. And this is the way, with the stitches on, this patient is able to move ankle, move the toes, and that's what I encourage in every patient. No plaster, no slab. And there is an article which tells you what are the ways you can avoid complications, because I feel most of the orthopedic surgeons are scared to do calcaneum or open reduction because they feel there are a lot of complications. So just read this article, but I have to give you the gist of this article. You must have a reasonable interval from the date of injury. You must do your case selection well, must know the lifestyle and comorbid issues of your patient, the placement of incision, the vertical limb, the horizontal limb, and the neurovascular issues. You must be careful. Gentle handling of flap is very important. The surgery should be finished within stipulated tourniquet time as far as possible. Then suction drain should be put, layered closure should be done, and you should learn to do Algover Donati sutures, which do not come on the side of the flap. So they come on the non-flap side, which also are important to do a good healing for the flap. Thank you.
Thank you, Dr. Dureja. You have given very good tips, and I think if someone will be starting and in any doubt, he may contact you also. So we are running short of time, sir. So everything has been clear. So I wish that there must be no questions. Is it okay, sir? Dr. Shantanu?
Sir, I have one or two questions, sir.
Okay, just hurry up.
Sir, in case of badly comminuted fracture or skin condition is not good. So, is there any space to use K-wire or JES in such cases? Or in other way, if patient is having some peripheral vascular disease like or chronic smoker or diabetic patient, what is your suggestion to for these patients, sir?
So first of all, if there are any issues which will pose a surgical risk to your flap, whether it is bad comorbid condition or whether it is a bad comminution, it's better to not touch these people and tell them this is an irreparable calcaneum and we will just buy some time, let some healing take place, and you better go for a subtalar fusion after an interval. Putting K wires without reducing your fragments, you are posing a risk of infection to the calcaneum. And once the calcaneum gets an infection, people land up with amputation. There is no cure of calcaneal osteomyelitis. So please don't use K wires and leave the ends out. They are of no use because they will never reduce your fracture. They will never make the patient good. So don't do half-hearted thing. Better is leave them alone. Let an expert person either handle it, or leave it alone, and you do a subtalar fusion for him sometime later.
Thank you, sir. Thank you. Now I would
Thank
request
you, sir.
Dr. Jayant. Sir, please stop sharing your screen.
Sure, I will. Thank you.
Thank you, sir. Now I would request Dr. Jayant to please share your screen. Unmute yourself, Dr. Jayant. You are not audible, Dr. Jayant. Please unmute yourself. Can you hear, sir? Dr. Jayant, you are not on.
Yeah. Just a minute.
Yes, yes. Now you are audible.
Okay. Am I audible now?
Yes, yes.
Okay. So thank you, Dr. Siroli and Uttarakhand team for having me here. Pleasure to meet Pradeep and Puneet also, and to interact with Dr. Dureja and Dr. Agarwal. So a common concept is that every fifth metatarsal fracture is a Jones fracture. No, that's not right. And I'll take you through a few of my slides to show you what all encompasses a fifth metatarsal fracture and what exactly is a Jones fracture. So described first by Sir Robert Jones, and it is more commonly seen from second to sixth decade. Male predominance is there, and in younger patients, female predominance in the older patients. And it's commonly a result of sports activities, but also happen to non-athletics. So there are strong ligaments between the base of the fifth metatarsal and the cuboid and the base of the fourth metatarsal, which make this part of the fifth metatarsal relatively fixed. And the diaphysis of the fifth metatarsal is relatively mobile. So this difference in stability makes the metaphyseal-diaphyseal junction fracture more susceptible to delayed union and non-union. Based on this cadaveric study, you could see that a lateral band of the plantar fascia attaches to the plantar lateral aspect of the tuberosity, and the peroneus brevis tendon attaches to the dorsolateral aspect of the tuberosity, and the peroneus tertius attaches to the dorsal metaphysis. So the majority of the PBT footprints were found in zone 1, and that a hook plate placement demonstrated to be safe when strictly placed laterally at the proximal aspect of the fifth metatarsal. So classification is by Lawrence and Bott, and zone 1 are the tuberosity avulsion fractures. Zone 2 are your metaphyseal-diaphyseal junction fractures extending into the fourth and the fifth intermetatarsal joint. And then in zone 3 are the proximal diaphyseal fractures. So zone 1 fractures refer to avulsion fractures of the tuberosity with or without involvement of the tarsometatarsal articulation. This is caused by forces by the peroneus brevis tendon or the lateral band of the plantar fascia during foot inversion. Zone 2 fractures refer to fractures at the metadiaphyseal junction, and this is caused by forced forefoot adduction with the hind foot in plantar flexion. And zone 3 fractures are caused by acute excessive bearing of the region or chronic overloading, as in stress fractures. So these are distal to the fourth and fifth metatarsal base articulation. So the inferior healing potential is because the blood supply to the fifth metatarsal metaphysis is by a network of arterioles entering the non-articulating surface of the tuberosity. The blood supply to the diaphysis is by the nutrient vessels entering through the middle of the diaphysis, and which gives longitudinal branches proximally and distally. So the watershed area at the metaphysis-diaphysis junction, which accounts for the highest risk of delayed union and non-union of fractures in this region. So zone 1 fractures, a meta-analysis of 187 tuberosity avulsion fractures from 4 studies, and there was no significant difference in union and refracture rates between different conservative treatment modalities, whether it was a plaster or a crepe bandage. Functional treatments with early weight bearing provided better functional outcome and earlier return to work than treatment by short leg cast with non-weight bearing walking. and functional treatments like orthopedic shoes, Jones bandage dressing, or elastic bandage dressings. Another study, prospective study of 29 patients, fifth metatarsal in zone 1, and radiography was performed to assess the degree of fracture gap and metatarsal length. Gaps of 2 mm or less were given short leg cast, fracture gap of more than 2 mm, open reduction and internal fixation, and group C short leg cast only. There was significant decrease in VAS and AOFA scores regardless of the initial fracture gap and the type of management. And there was no difference seen in final VAS scores for patients with longer metatarsals when compared to those in whom the metatarsals were unchanged or shortened. LNB 1 and 2 fractures featured excellent results with immediate full weight bearing, and consequently should be summarized as epi-metadiaphyseal fractures. Fracture displacement, articular involvement, and number of fragments did not influence the outcome. Therefore, functional treatment should be recommended for all epimetaphyseal fractures. TOGS classification is for zone 2 and 3. Type 1 are the acute fractures with a narrow fracture line. Type 2 are delayed unions with a wide fracture line with intramedullary sclerosis. And type 3 are non-unions with complete obliteration of the medullary canal by the sclerotic bone. Zone 2 and 3 have a 95% union rate, satisfactory long-term results, satisfactory functional outcomes with non-operative treatment by short leg cast immobilization. The main disadvantage is the delayed union time and longer time to return to function. And 8 out of the 44 patients required secondary fixation due to delayed union. Another study, 37 patients, 18 patients casting and 19 patients screw fixation. Non-operative treatment had a higher rate of treatment failure, 44%, and doubled the time to clinical union and return to sports. Conservative treatment with non-weight bearing in a short leg cast for 6 to 8 weeks for acute fractures in the non-athletic group. And they recommended surgical fixation in athletic patients for earlier union and return to function. For delayed union and non-union cases, he recommends surgical treatment with or without bone grafting. So zone 2 and 3 operative options, well, usually we use an intramedullary screw, rarely a tension band wiring or a differential pitch screw, but cutaneous bicortical screw and hook plate are very rarely used. So fixation with intramedullary compression is the most commonly reported technique. Reaming of the medullary canal before screw insertion is advised to ensure tight fit of the screw to the endosteum. A partially threaded screw is used and all the screw threads must pass through the fracture line in order to achieve fracture compression. No correlation between the size of the screws and biomechanical advantage. A larger screw may provide a better pull-out strength, but may also increase the risk of diaphyseal fracture during insertion. 100% union rate, high satisfaction, and no refracture in a group of high physical demand athletic patients using a 4.5 mm cannulated intramedullary screw fixation. And similar excellent result was also demonstrated in another recent study. TVW is an alternative procedure, comparable outcomes, and risk of sural nerve injury and neuralgia is reduced as per this study from Korea. Variable pitch screw and percutaneous bicortical screw have been previously described, but clinical evidence is limited. Retrospective review of 37 professional football players following intramedullary screw fixation showed a mean return to play at 10.5 weeks, a mean time to complete radiological union at about 12.7 weeks, and return to play at 8 weeks or less resulted in a higher risk of delayed radiological union, that is 24% at 3 months. But this never prevented the athlete from continuing to play football, nor did it affect the ultimate risk of non-union. Post-op rehabilitation is a short leg cast or a plaster sprint for 2 weeks and then a walking boot. Progressive weight bearing from 4 weeks onwards. At 6 to 8 weeks, full weight bearing is allowed and normal activities can be resumed. Return to sport should be allowed when there is radiological evidence of union and the patient is clinically asymptomatic. The rehabilitation plan must be accepted by the patient preoperatively, since premature return to vigorous physical activity is believed to cause delayed union and refracture, especially in athletic patients. What are the contraindications for surgical treatment? Well, feet with vascular compromise, neuropathy, or local infection. Diabetes mellitus itself is not an absolute contraindication, providing the vascular supply and the protective sensation of the long extremities are still intact. A summary of the complications: delayed union, non-union, and refracture. A low non-union rate of about 0.5 to 1% was reported in zone 1 fractures. Non-union rate of zone 2 and 3 fractures treated conservatively is as high as 25 to 28%, and a delayed union rate of 66.7% and a refracture rate of 61% for zone 2 and 3 fractures in another study. So, for tuberosity, avulsion fractures, failed conservative treatment, screw fixation with or without bone graft, and excision of the extra-articular avulsion fragment are the treatment options. For fractures at zone 3 and 2, non-union and refracture should be treated by medullary curettage and inlay grafting or intramedullary screw fixation. Revision in previous screw fixation: a larger diameter screw and a re-reaming of the medullary canal is required. And tension band wiring is the secondary procedure for delayed union or non-union with prior unsuccessful conservative treatment or intramedullary screw. So, wound infection, rupture of peroneus brevis tendon, peroneal nerve irritation, sural nerve injury, impingement by prominent screw head, screw missing the medullary canal has been seen, an iatrogenic fracture of the metatarsal bone and metatarsalgia if the screw size has been too big or its angle has not been correctly placed. So, take home message: proximal fifth metatarsal fractures are common. Knowing the anatomy is important. Classification is by Lawrence and Bott and by Togg to help formulate appropriate treatment strategies. And fifth metatarsal fractures associated with Lisfranc injury must be distinguished from isolated proximal fifth metatarsal because their prognosis is different. Avulsion tuberosity fractures should be managed conservatively with functional treatment. Zone 2 and 3 are more prone to delayed union. Acute cases, conservative treatment with cast immobilization and non-weight bearing in non-athletic group. In athletic group, early surgical fixation with intramedullary screw fixation is advised. For cases of delayed union, again, treatment with bone grafting is recommended. Post-operatively, rehabilitation should be planned. Complications of fifth metatarsal fracture include delayed union, non-union, refracture, soft tissue complications, and implant impingement. And they are prevented by careful soft tissue handling, proper surgical technique, and suitable choice of implant. So make sure that the screw size is appropriate. Symptomatic delayed union, non-union, and refracture should be treated with revision, intramedullary screw fixation, and bone grafting. Thank you all. I hope it was worth it.
Thank you, Dr. Jayant. It has been a very much common fracture. In fact, we get it one or two every month. So very common problem, and you tackled it very nicely. Dr. Pradeep, would you like to comment?
Yes, sir. Sir, how often do you use bone graft in zone 3 fractures? They are mainly due to stress injuries.
Yeah, so if I need to use it, then I make a small, about a 1 centimeter incision on the lateral aspect in the calcaneus, bur it from there, and just put it in the graft area, in the non-union side, and then tighten the intramedullary screw.
Sir, I was asking how often do you use bone graft?
Not very often, frankly. You get a very good compression, and that works.
And what's your implant of choice for zone 2 and zone 3 fractures? Intramedullary screw or plates?
I prefer to use intramedullary screws, and usually they are the 4.5 mm intramedullary screws.
So what do you use to bury the head of the screws?
So the head is not a problem because I don't go from the base, but I go from the inner aspect. So your entry point, if it is right, then
yes. As like
both
in
the problems
fingernail,
are
we
taken
go
care
through
of. The implant
piriformis fossa.
impingement is also taken care of, and also the chances of your misdirected screw going into and causing an iatrogenic fracture are also taken care of because it's going directly intramedullary.
Sir, in zone 1 or zone 2 injury, what treatment you are using in non-athletic group?
Sorry, Puneet, I couldn't catch you.
Sir, in non-athletic population, in zone 1 and zone 2 injury, what treatment you are giving, sir? Conservative treatment.
So in zone 1, we are actually giving functional treatment, which would usually be a crepe bandage support, icing the patient, crepe bandage support, and early immobilization. But in zone 2 and 3, we would be giving cast to begin with, and we would be making the patient weight bearing with support. And as per pain, they could get rid of their support also in the non-athletic patients. Yeah.
Any other question from the panelist?
So the clear message is that you have to divide between the athletic and non-athletic group, and then devise the method accordingly.
Divide into
Right,
the
sir?
zones and divide into the athletes and non-athletes, and then go accordingly.
Hello. Sorry, I couldn't get the question, Dr. Siroi.
It was not a question. It was the observation that you have to divide into two, athletics and non-athletics.
I think there is no more questions from the panelists. So, sorry,
Dr.
sir.
Dureja, would you like to comment?
Well, what I do is I use Hubbard screws for this situation.
Okay.
And I have Hubbard screws which are, 4.5 millimeter in the front, 5.5 millimeter on the back. So this differential diameter produces a compression. Then I have these screws which are coming as 4.5 in the back and 3.5 in the front. Similarly, I have screws which are 6.5 at the back and 5.5 in the front. So these three set of screws are specially designed. And what I do is when I pass a drill bit, I pass it on a simple hand reamer, kind of thing. I use the drill bit as a reamer. So I know where my drill bit, starts struggling. So that is the kind of diameter I need in the front in the diaphysis. And that's how I select the appropriate Hubbard screw and impact it within the base of the metatarsal, and it does not give any impingement to the peroneal brevis tendon, which is a very important tendon here. And a head protruding out of the metatarsal can produce an impingement of the peroneal brevis and give a constant pain to the patient. So adopting a technique of using a Hubbard screw with 1 millimeter differences has done away with this problem and given me pretty good results.
So you get long Hubbard screws?
Yes, all sizes, all
Okay.
sizes.
And you put the drill on your T-handle?
T-handle, yes.
Okay.
Kamal sir, in which condition will you advise TBW in fifth metatarsal fracture?
That would be which are non-zones, which are basically the zone 1 and 2, Zone 1 specifically, where you have an intra-articular component. It works like an avulsion fracture. So TBW is your technique for avulsion fractures, like avulsions of the ulna, avulsions of the medial malleolus. So you are handling a situation where the pull of the peroneal brevis has actually produced the avulsion. So that's a place where TBW has a very good role.
So I think.
Any other question? Sorry,
Pardon?
sir, any other question?
Any questions from the audience?
No, there is no question
No
from the
question.
audience. Any panelist?
So that was
Dr.
a
Pradeep,
nice
sir?
discussion,
And so it was all
Dr.
good.
Jayant. Yes, Dr. Pradeep, you want to say anything?
No, sir, it's fine, sir.
So that was a nice discussion. I hope the audience must have got the messages very clearly. and we in Uttaranchal Orthopedic Association are now committed to take it to for more of the symposiums. Our next symposium will be on the hip, and it will be about the correct entry points and tips and tricks in the intratrochanteric and subtrochanteric fractures by Dr. Shiv Shankar on the next Thursday. So thank you panelists and thank you speakers for the such a nice topics discussed here so thoroughly. I would request Dr. Puneet to please give a vote of thanks from the side of Uttaranchal Orthopedic Association.
Yes, yes. Thank you, Jain sir. Thank you, Kamal sir. Thank you, Naresh sir, for the nice presentation. And thank you all panelists, Dr. Shantanu sir, Dr. Pradeep sir. Thank you, OrthoTV team. And thanks to all our delegates.
Thank you
sir.
once
Have a
again
good
for
night.
having us here, and it was a
Good
pleasure
night, sir.
to
Good
be a
night,
part of the
everybody.
event. Thank
Thank
you, and we
you, sir.
look forward to another
Thank
one.
you, everybody. Thank you.
Thank you.
Namaskar,
Thank you.
sir.
Thank you. Good
It was
night.
nice
night, sir.
interacting with you, sir. So nice, sir. Thank you.